A1 Logics. President, sir, you can commence the proceedings.
Yeah, we will start, sir. Good evening, everybody. We have joined here. Welcome to our 43rd edition of Pudukkottai Budan, an online weekly webinar program from Indian Society of Anesthesiologists, Pudukkottai branch, a branch from Tamil Nadu, India. We have today some interesting topics on regarding cardiovascular system, and some eminent speakers have joined here, and we have an eminent person as chairperson. Now I welcome our Secretary, Dr. Periyasamy, to deliver the welcome address. Over to Dr. Periyasamy.
Thank you, sir. Respected Academic Chairman, Dr. 11Jan2023 sir, President Dr. Suresh Kumar sir, President Dr. David, members of ISCA Pudukkottai, and delegates, those who are attending continuously on the online ISCA webinar program, Pudukkottai Budan. On behalf of ISCA Pudukkottai, I welcome you all for the third continuous online ISCA webinar program. This is achieved because of our academic chairman, Dr. 11Jan2023 sir, for his hard work and continuous, because of his hard work and continuous supporting of ISCA Pudukkottai tirelessly with all sort of support. Once again, I would like to thank our academic chairman and team of ISCA Pudukkottai, including our president, Dr. Suresh Kumar sir, treasurer, Dr. David, and members of ISCA Pudukkottai. Once again, I welcome you all for this 43rd ISCA webinar program. So we already covered so many topics. The topics listed here, we can go through if you want. Today we are having 3 topics for this 43rd ISCA webinar program. First one is introduction of cardiac pressure volume loop, and next one is management of how I manage hypertension, that is management of hypertension, and third one is CPR in prone position. It's a different position to learn everyone, a CPR in prone position. For that, I welcome Dr. Manjunath HCE, Professor and HOD, Mysore Medical College and Research Institute, Mysore, as a chairperson. I welcome you, sir, on behalf of ISCA Pudukkottai. Next, we are having eminent speaker, 3 eminent speakers. First is Dr. S. Parthasarathy from our own soil of Tamil Nadu. Parthasarathy, Professor, Mahatma Gandhi Medical College and Research Institute, Pondicherry. So he is going to talk about introduction to cardiac pressure volume loop. I welcome you, sir, on behalf of ISCA Pudukkottai. And next speaker, Dr. Vijish Vedagopal, Professor and HOD, KMCT Medical College, Calicut, Kerala. So I is going to talk about how I manage hypertension. I welcome you, sir, on behalf of ISCA Pudukkottai. And third speaker, Dr. Pradeep, President, Mysore Medical College and Research Institute, Mysore, Karnataka. So I is going to talk about CPR in prone position. On behalf of ISCA Pudukkottai, once again I welcome you for this 43rd ISCA online webinar program, Pudukkottai Budan. So if you want any clarification or doubts, you can send your queries and other details to isapudukottai@yahoo.com. This is our registered ISCA Pudukkottai ISCA Pudukkottai Yahoo address, Yahoo mail address. You can contact me at any time with anyone. So today we are going to talk about some cardiac events. So I want to give some small summary about cardiac cycle. It is event between lump and dub sound. It is an event between filling and emptying of cardiac chambers. Cardiac cycle, it is an event between opening and closure of valves, cardiac valves. It is an event between positive and negative pressure of heart chambers. Cardiac cycle, it is an event between systolic and diastolic of heart, and it is event between systemic and pulmonary circulation. So cardiac cycle, it is an event between breathing and beating. Cardiac cycle, it is event between atomicity of heart and arrhythmicity of heart. With this, I welcome you all once again and thank you for the opportunity. Over to President Dr. Suresh Kumar, sir. Thank you, sir.
Thank you very much, Dr. Periyasamy. Dear Secretary Periyasamy, my treasurer, Dr. David, our branch academic chairman, Professor Dr. A.L. Meenachitrandaram, Director of Medical Education, members and office bearers of ISA Pudukkottai branch, respected professors, Dr. Parthasarathi sir, Professor Dr. Vijish, and Professor Dr. Manjunath, and Dr. Pradeep, resident from Mysore. I welcome you all for our program. A short note about our Pudukkottai Budan. Pudukkottai Budan is an online weekly webinar program, an educational initiative from ISA Pudukkottai branch. Thanks to our academic chairman for bringing out this very practical and wonderful initiative. We have been focusing on so many topics of anesthesiology for the past 11 months. Our target is mainly to educate the upcoming postgraduates, residents, practicing anesthesiologists, and though by incorporating so many specialists all over from India in this platform, so that the educational aspect of anesthesiology is being forwarded to our younger generation. The main idea and the selection of topics, speakers, and conduction of this Pudukkottai Budan goes to our academic chairman. Once again, on behalf of ISA Pudukkottai branch, I extend my thanks to our academic chairman. Today we have some interesting topics which everybody should know. First, the resident is going to talk on a different aspect, how to do cardiopulmonary resuscitation in a prone position. We are routinely doing on supine position. So this everybody should learn. And I think our Dr. Pradeep will throw light on that. And next topic is Professor Vijish Venugopal sir is going to talk on how I manage hypotension in anesthesia as well as in life. I think he will bring out how to manage hypotension for everybody as we frequently face hypotension in our practice. And last, our Professor Parthasarathi sir is going to deliver interesting topic on cardiac pressure volume loops, which is coming very fastly for monitoring cardiac events. I think this webinar will be useful for everybody. At this juncture, I request everybody to make use of this juncture by patiently listening, and at the end, you participate on the discussions. We have all the topics to coordinate and conduct. Nice chairperson, Professor Dr. Manjunath sir from Mysore. And at this juncture, as president of ISA Pudukkottai, I welcome you all to this webinar, 43rd webinar. Now I hand over all the proceedings to our academic chairman, Dr. A.L.M. sir, to conduct this webinar. Thank you, and over to Dr. A.L.M. sir.
Thanks, Dr. Suresh Kumar sir, President ISA Pudukkottai, respected Secretary, Treasurer, and members of ISA Pudukkottai, and the distinguished faculties, Dr. Pradeep, Dr. Vijish, Dr. Parthasarathi, Dr. Manjunath. At the outset, I have to say, our President remarked, Dr. Manjunath is a nice chairperson, but the nice chairperson is now attending a meeting with the Honorable Minister of Health in Karnataka, so that a nice chairperson will be replaced by this man. Whether it is nice or not, you have to accept it, because 1 hour back only he was called for a meeting, and we don't know when the meeting ends. But once the moment the meeting ends, he will be joining. So Dr. Manjunath is HOD of Mysore Medical College and Research Institute. Just because he is not available, he has placed his representative, sapling, Dr. Pradeep. So Dr. Pradeep is from Tamil Nadu. Actually, he is native of Salem, but he is settled in Bangalore. As Bangalore is very nearer and more glamorous than Salem, he has opted for Bangalore and comfortably settled there. He is a final year resident in Mysore Medical College, and he is going to deliver a lecture on how to do a CPR in a prone position. So everybody is waiting for that, and this man is interested not only in playing cricket, even he is interested in seeing that cricket match. So watching is his hobby. So even if somebody else scores a century, he will feel proud of it. So he is interested in watching what are poor chap, what a doctor can do. He can simply see. So he is doing that. So it is a good platform. He is co-faculty with Dr. Vijesh and Dr. Parsardi. See, Dr. Vijesh is well known across the country. So he is a dedicated cardiac anesthesiologist, but he is so humble. He will not reveal that he is such a big man. So he is a national faculty known to all the anesthesiologists in the country, and he is most popular among the cardiac anesthesiologists, and he is a professor in KMCT Medical College, Calicut. He is a governing council member of ISA Kerala, and he has won the best paper award. So even from the days of PG, he is a best outgoing student. He is such a great man, but down to earth man. In Indian College of Anesthesiologists, his role is phenomenal. He is conducting the meetings. He was conducting webinars for ISA Kerala postgraduates and ISA South Zone postgraduates. See, his ECG quiz, X-ray quiz, everything is popular. See, I came across Dr. Vijesh only by this Kerala webinar and attending Kerala meeting. So he is such a great man, and it is fortunate to have him for ISA Pudukkottai. And naturally, Dr. Parsardi used to ask me, why you have left Dr. Vijesh so far, up to 43rd week. I said, already I have contacted him twice, but he is continuously engaged in webinars. That is the problem. So just because he could not travel, but he is a much sought after speaker. And at last we have fixed him, Dr. Vijesh. And Vijesh, the topic itself is very interesting. How I manage hypertension. Because whenever a patient develops hypotension, anesthetist will develop hypertension. So once that hypotension comes to hypertension, this hypertension goes to normal tension. So that's what he is going to manage. So with a ever smiling face, he is going to manage the show, how to tackle hypotension without developing hypertension ourselves. So I congratulate him and I thank him for accepting our invitation. And that third faculty is Dr. Parsardi. If we talk about Dr. Parsardi, it itself will be a webinar. So Dr. Parsardi may not have adequate time like Dr. Vijesh. Vijesh is addressing from OT in the theatre dress. So Dr. Parsardi, he himself is a versatile speaker. He has conducted continuously, it is countless number of webinars every week on a Friday. It is called Fridays. And if we talk about his qualification, it will have more letters than his name. So he is a professor in Mahatma Gandhi Institute of Medical College. In all branches of anesthesiology, he is interested. He is a diabetology man. He is acupuncture man. What not? He is qualified in everything. This ultrasound guided nerve block and whatever is new. And another point, he knows all the national faculties with a phone number. So if you want to have any faculty, you can contact Dr. Parsardi. He will immediately give the thing. And Dr. Parthas, Pain Free Parthas, is a popular website. Then he is the one who is offering his PowerPoint free of cost in an open website. So if I say he is one of the anesthesiologists, means number two may be me. If you ask me, I will send the PowerPoint. Because we used to say, just by a PowerPoint, some people are thinking if a PowerPoint is shared, they will excel. It is not like that. So the power behind the PowerPoint is the speaker. So that way, Dr. Parsardi is a popular person. Now this faculty team, see, one from Tamil Nadu, Dr. Parsardi, one from Kerala, Dr. Vijish, and one from Karnataka, Dr. Pradeep. So every time ISA Pudukkottai proves it is conducting a national webinar. So many times we are having speakers from different state. Even sometimes chairperson is from a different state. All the four will be different state. We are continuously proving that. And even why I had a lengthy introduction means even the beginning, sharply we begin the session by 6 o'clock. So 6 o'clock, 50 people will be entering. Now 60 people have entered. So that shows people are interested in cardiac physiology. And whenever hypotension occurs, people sometimes they call cardiologists even for post-op hypertension. But now that hypertension is going to be dealt with, pressure volume loop, Dr. Parsardi will tell he is interested in basic physiology. This man is going to talk about prone CPR. So without taking much of a time, just because the chairperson is not available, I have taken his time also. Now I request Dr. Pradeep, even though he was expecting his HOD as a chairperson, now he can happily present because that examiner is not here to assess his views as internal examiner. So Dr. Pradeep, you can go ahead. Please tell us how to manage a CPR in prone position.
Thank you, sir. Thank you so much for the opportunity to present the topic today. So I'll go right ahead and start with it. Every one of us are very much aware of cardiopulmonary resuscitation in the supine position. So, and right now, since 2019, with the ongoing COVID pandemic, and with patients, more and more patients being nursed in the prone position with active proning of the patients, improving the oxygenation, we see a lot of patients with hemodynamic instability having undergoing cardiopulmonary arrests in the prone position. Or we as anesthesiologists can also come across cardiopulmonary arrest in prone position during surgeries like neurosurgeries, spine surgeries, even some renal surgeries also. So what exactly to do and how to go ahead with it, I'm just going to give a short talk on that. So as we all know, the mechanism of CPR is basically the thoracic pump mechanism, whereby the changes in the intrathoracic pressure brings about the venous return and helps in the circulation, and the cardiac pump theory, which states that the pressure generated by our CPR efforts, the pressure over the sternum in turn causes pressure inside over the ventricle chambers, which raises the intraventricular pressures and pushes the blood column forward. So these are the two theory which operates and helps in the circulation during cardiopulmonary resuscitation. The same theory applies during prone CPR also. So what are the advantages of the prone position? So in the prone position, the pulmonary functions are better than compared to the supine position. There is superior ventilation perfusion matching, more in the posterior segments of the lung. And especially because the heart, the effect of the weight of the heart and the abdominal contents are also relieved from the dependent positions of the lungs, and they are aerated better, and this helps in better oxygenation as and also increases in functional residual capacity, thereby with ARDS and COVID. So this diagram illustrates the effect of prone position with the position of the heart in various and how it helps in the oxygenation. The concept of prone position was actually not a new one. It was first described by Dr. McNeil in 1989. And it came into foresight, or it came a claimed success once it was practiced by Dr. Sun and colleagues in 1992. They put forward the first case of successful ROSC in prone CPR. But its importance, as I told earlier, has tremendously increased after COVID-19 pandemic, where proning is increasingly practiced. So is it recommended? So if you see the various recommendations put forward, the UK Resuscitation Council recommends starting chest compression without changing position in patients who arrest during neurosurgery. And even the AHA guidelines, the prone position CPR was included from the 2010 guidelines and has been there ever since. And it states that, as you can see, this is the latest 2020 CPR guidelines, in which it says that when the victim cannot be placed in supine position, it may be reasonable for the rescuers to provide CPR with the victim in the prone position, particularly in hospitalized patient with an advanced airway in place. So AHA also recommended, and it had been given special importance during the 2019 interim guidelines for COVID-19 states, because they wanted to reduce the amount of aerosolization. Shifting the patient supine, especially the ventilated patient, there'll be a lot of aerosolization of the infective material. So to prevent this also, prone CPR could be initiated. So always there has the knowledge or the data associated with prone CPR has been very less. There's only been through case studies or pilot studies, and there is no proper RCTs conducted so far. So there is always a knowledge gap which has existed when it comes to prone CPR. So why prone CPR is would be advantageous? So what are the
sheets?
What are the risks of flipping the patients to supine position before CPR? So first and foremost is the time delay. So as we know, in cardiac arrest, each and every second is very important, and there'll be a time delay of seconds to minutes in shifting the patient from prone to supine. So this can be avoided by immediately starting compressions in the prone position. There may be more helping hands required to shift the patient supine. And while shifting, there may be dislodgement of vascular lines, endotracheal tubes, or disconnection from the ventilator and aerosolization. And rapid changes in position can lead to hemodynamic instability, or patients who are already hemodynamic unstable can lead to worsening of the condition. Even patients who are oxygenated can lead to hypoxemia in the supine position. And also, while especially in surgical cases where the patients have been fixed with various supports and clamps and stands, they can be lead to potential injury to the patient, staff, and this most common in obese patients also. So what is the procedure of prone CPR? So the rules, there is no proper algorithm as such for prone CPR. It's the algorithm to be followed is as per AHA guidelines for supine CPR. It's only the position, the hand position and the position of defibrillation pads which are going to vary when it comes to prone CPR. So the methodology and the algorithms, the step-by-step to be followed is as per the supine CPR guidelines of AHA 2020. So the steps are similar to CPR in the supine position. The main difference lies in the position of the hands for compression. So various studies have shown various positions. Sun et al. Came forward with a reverse precordial compression technique, where one hand of the patient one hand of the rescuer is placed over the patient's back over the mid-thoracic spine, while the other hand is formed into a fist and placed against the lower third of the sternum to act as a support. If two rescuers are present, then one can apply the sternal support from below using a fist, and the other can go ahead with compression with both the hands on the mid-thoracic spine. And Tobias et al. Reported a case where there was return of spontaneous circulation with chest compressions in prone position, where both the hands were placed over the two scapula at mid-thoracic level, and compressions were given. And in this case, since it was mostly a scoliosis corrective surgery, the patient was already placed on a supportive frame, so there was no need of any sternal support. So this type of chest compressions can be given in patients who are undergoing any midline back surgeries, especially spine surgeries. The wound site won't be affected while giving this type of compression. To identify the best area for giving compression, No and et al. Did a study where they took CT images of patients, and they came to the conclusion that almost 86% of the patients, the best area or the largest ventricular surface area corresponds to 0 to 2 segments below the level of inferior angle of scapula, making this the best region. So as per AHA guidelines, the best level would be from the level of T7 to T10 vertebral bodies over the thoracic spine midline. So these are the images showing where the hands can be placed. This showing the midline with the sternum in a fist to give support, while the other hand is used for compression. And this is two hands over each scapula to give compression. So where should be the defibrillator pads placed? So the pad position should allow sufficient energy to pass through the myocardium. So the various recommendations include the antero-posterior position, where one pad is placed anteriorly over the sternum, the other over the midline, posteriorly over the mid thorax. They alternatively, the pads can also be placed in both the axilla by axillary position, or that can be in the posterolateral position, where one pad is placed in the left axilla and the other pad may be placed over the left scapula or the right scapula. Both are equally efficient. So is prone CPR effective? So various studies suggest prone CPR generates higher blood pressures as compared to supine position. So Wei et al. Compared CPR found prone CPR generated greater systolic pressure as compared and diastolic pressure as compared to supine position. So what they did was this was done in cadavers where initially CPR was given with the intra-arterial BP monitoring. CPR was done in supine position, and then the cadavers were turned prone, and again CPR chest compressions were given and the blood pressures were compared, and it showed a greater systolic pressure in prone position. There was another study also in which patients, ICU patients underwent supine CPR, and when supine CPR was found to be when almost after 45 minutes of supine CPR, since it was found to be ineffective, they were placed in prone position just to measure if there is any rise in blood pressures, and even in that study, it showed higher blood pressures were generated in prone position. And in healthy volunteers, they measured the tidal volume generated while giving chest compressions in the prone position, and it was shown to generate around 400 ml of tidal volume. And this was suggestive that prone CPR can be given even in patients who are not intubated or who do not have an advanced airway in place. But still more studies were required. So they even it showed prone CPR can generate a high end tidal CO2 of up to 18 to 33 mmHg also. So this the theory behind it was suggested. The theory suggested was that compared to the in supine position, where the costosternal or costoclavicular ligaments are more lax, but the costovertebral junction or costovertebral joints being more stiff can generate transmit the pressure better over to the heart as compared to the supine position. So this could be the reason why there are higher pressures generated in the prone position, even though the venous return might be impaired. So what are the survival rate? There are little evidence evaluating long-term outcomes. There is very few studies there to comment on prone CPR, and most of it being case reports and case series. They report a good survival rate and hospital discharges. Almost 23 out of the 31 case series showed the return of spontaneous circulation in prone position and recovery of the patient and discharges. But there may be a lot of bias involved in these studies, and we require more streamlined and more proper studies to to establish the survival rate. So to conclude, I would like the incidence of cardiac arrest requiring prone CPR is expected. although always conventional CPR is the gold standard, the knowledge and art of learning prone CPR is always not a harm. And even though always as per the recommendations, if possible, prone CPR should be started. It, at least if not help in return of spontaneous circulation, it might actually help to at least bridge the time between the patient arresting and between to the patient being put in supine position. So instead of waiting and instead of the latency there, immediately initiating prone CPR would at least help in the resuscitation processes. So even though we have a lot of case series and studies, we need more streamlined and more randomized controlled trials to establish the efficacy of prone CPR. And so we need more like how for supine CPR there is a algorithm. We will have to come up with a algorithm for prone CPR if studies are established. So these are the references I used for my presentation. So thank you for the opportunity.
Thanks, Dr. Pradeep, for the wonderful presentation. So whether this prone CPR is scientifically successful or not, something is better than nothing. So even before shifting the patient to supine position, we can do this prone CPR even if we wish to do it at a later time. So something is better than nothing and nothing is better than nonsense. But prone CPR is definitely not a nonsense. So it has some sense. So the question, the suggestions, feedbacks, clarifications that can be kept in the chat box, everything will be taken at the end of all the 3 lectures. Now, Dr. Vijish Venugopal will present his subject, how he manages hypotension.
Yeah, good evening, sir. Yeah. Good evening. Am I audible?
Yes, sir. Dr. Vijish, yes.
It's moving also, right, sir? So good evening, all. I would like to, at the outset, thank Pudukkottai Buddhan for the opportunity, especially Minashi sir for the kind invitation. And I've taken the liberty to just modify the topic as how I manage hemodynamic instability. And there are no conflicts of interest. Now, hemodynamics is concerned with the forces generated by the heart and the resulting motion of blood through the cardiovascular system. So it's either the intermittent or continuous observation of physiological parameters that pertains to the circulatory system with a view to early detection of need for therapeutic interventions. Now, we all can ascribe the birth of hemodynamic monitoring to the British anesthesiologist who specified that, Joseph Clover, who was very particular that we should have the pulse, or we should have the finger on the pulse while we administer chloroform anesthesia. So what is hemodynamic optimization? The ability to optimize hemodynamics to ensure adequate organ perfusion and improve clinical outcomes is one of the many holy grails in anesthesia and intensive care. Now, which hemodynamic targets we should aim at to optimize patient outcomes is still elusive and controversial. Now, how to use and interpret these targets is the core issue based on a physiologic point. We should all remember that one size does not fit all, and we should personalize the management. The high-risk surgical population, they have a very poor cardiopulmonary reserve, and it is our duty to optimize these patients before we take them up for the surgical intervention. If the impaired oxygenation balance is not corrected early enough, mitochondrial damage will take place and the insult will become permanent. And then there is no use of giving any goal-directed therapy to these patients. So if you have a patient with hemodynamic instability, there are only 3 things that are available in the operating room or in the ICU for improving his hemodynamic status. So the three therapeutic options are either you can give a vasopressor, or you can give an inotrope, or you can give fluids to cause volume expansion. Now you have to decide what to give at what time. So for that, we have to use the hemodynamic monitors that are available to us either in the ICU or in the operating room. So there are three things that we have to find out from the hemodynamic monitoring. Either the patient is vasodilated, or the patient has an impaired contractility, or the patient has a volume responsiveness. So if these things are available, you have to titrate your management according to the condition that the patient has. So suppose the patient is vasodilated. How do you know that the patient is vasodilated? You can look at the diastolic blood pressure on your invasive blood pressure monitor. And if you find that the diastolic blood pressure is low, that means the patient is mostly vasodilated. If his hematocrit is normal during the surgery, or you can have a more objective way of saying that the patient is vasodilated by looking at the systemic vascular resistance. So how do you look at the systemic vascular resistance? You can either use the PA catheter or the flow track monitor. So if you have this, you can get a objective idea whether the patient is vasodilated. If the patient has a low systemic vascular resistance, that means the patient is vasodilated. And in such patients, we have to ideally start a vasopressor like norepinephrine or vasopressin. The next scenario that we face is whether the patient is volume responsive. So, but when to give fluid, it is very important to know when to give fluid and when to stop. So we will see when we should give fluid, what should be the ideal situation where you will give fluid. So when to give fluid, you have certain static indices as well as dynamic indices to be responsive. The static indices are the CVP and the pulmonary artery occlusion pressure. Whereas you have the newer modality, that is the dynamic indices like the pulse pressure variation and the stroke volume variation. Now, if you look at the CVP as well as the pulmonary artery occlusion pressure, they are not very accurate in predicting the fluid responsiveness. It is just like flipping a coin. Either it can come heads or tails. So 50% of there is only a 50% chance of predicting fluid responsiveness by using the static indices of the CVP and the pulmonary artery occlusion pressure. So it is recommended that we use the PPV, that is the pulse pressure variability and the stroke volume variability. So how do you decide to give the fluid? So either you can go for a restrictive fluid therapy or the liberal fluid therapy. But there are certain problems when you restrict fluid, like you can have hypovolemia, dehydration, low cardiac output, or renal dysfunction. If you are very liberal in your fluid therapy, you could go in for tissue edema, pulmonary edema, cardiac failure, and poor wound healing. So you should give just the right amount of fluid. So how do you do that? You use the dynamic indices. Now the dynamic indices are possible once the patient is being ventilated. And you can see that the stroke volume and the pulse pressure variation can be seen along with the when the patient is being mechanically ventilated. You can see with the initiation of ventilation, there is a compression of the right ventricle and the blood pressure slightly increases because of the increased preload to the left ventricle. But later on, you can see that due to the impediment of venous return, there is a fall in the blood pressure. So this variability has been quantified. If you have a pulse pressure variability that is less than 10, that means the patient does not require fluid. But anything that is more than 15, the patient has to be given supplemental fluid. Now, suppose the patient has arrhythmias. So this is done when the patient is being mechanically ventilated. Now, suppose the patient has arrhythmias or the patient is on spontaneous breathing. In such patients, we cannot rely on pulse pressure variability or the stroke volume variability. You'll have to do either a end expirate. You should do a passive leg raising test. So what is passive leg raising test? In passive leg raising test, what we do is we tend to recruit the volume in the splanchnic circulation and in the lower limbs. So you should do a passive leg raising from a semi-recumbent position to a passive leg raising rather than from a horizontal position to a passive leg raising. So in this case, what is being done is you're inducing a reversible auto transfusion. And what will you look at? You will be looking at the change in the cardiac output. The problem is you should be able to get a more than a 10% increase in the cardiac output to say that the patient is fluid responsive. Now, suppose this is not possible in patients who either in the operating room, this cannot be done in the operating room, and also it cannot be done in patient who has undergone who has a head injury. So this is contraindicated in these two conditions. And it cannot be done in patients who have intra-abdominal hypertension. If the patient has a intra-abdominal pressure of more than 16, you cannot recruit the splanchnic circulation into the central circulation. So these are the cases in which you cannot do a passive leg raising test. Now, suppose the patient is on a mechanical ventilator and has ARDS, and he's being ventilated with low. Usually, patients on ARDS are usually ventilated with 6 ml per kilogram of tidal volume. And what you can do is you can do a tidal volume challenge. In these cases, you can increase the tidal volume to 8 ml for a few breaths and see what is the change in the pulse pressure variability. If there is an increase in the pulse pressure variability of more than 3.5%, these patients are also fluid responsive. So you can give them fluid. Another way of checking in patients who are mechanically ventilated but probably have arrhythmia, in these patients you can do a end expiratory occlusion test. What is done here is at the end of expiration, you stop the ventilator for around 30 seconds and see what is the rise in cardiac output. So if you find that there is more than 5% increase in the cardiac output, it is indicative that the patient is fluid responsive. Now, what this test does is when you occlude when you stop ventilation at the end of expiration, the cyclical impediment to venous return is removed. So there is if the patient is fluid responsive, there will be an increase in the cardiac output. So these are some of the ways in which you can see when to administer fluid. You can test whether the patient is fluid responsive. So we know now when to give fluid. Now the other thing to know is when to stop giving fluid. So one is when you have negative indices of tests of fluid responsiveness. You have done all the tests, the previous tests, and you have seen that the patient is not fluid responsive. That means he's not on the favorable part of the Frank-Starling curve. The other way is to look at the lung water. You can see the lung water. You can quantify what is the lung water if you have what is known as a PICO monitor. If you have a PICO monitor, you can look at the transpulmonary thermodilution technique of cardiac output monitoring, and you can find out what is the extravascular lung water. Usually, the extravascular lung water is around 7 ml per kilogram in a patient, and anything that is more than 10 ml per kilogram is considered to be increase in extravascular lung water, and in an increased case, you should not give fluid. The other way would be to do a lung ultrasound and quantify the number of B lines. If you find that the B lines are 7 millimeters apart, you can say that the patient has interstitial edema, and if it is less than 3 millimeters apart, probably the patient has a alveolar edema. So that gives you an idea of when to stop fluid. And the third part is the contractility of the patient. Now, the contractility can be well known from doing a transthoracic echocardiogram. You can do either a transthoracic or a transesophageal echocardiogram. Nowadays, we have hemodynamic transesophageal echocardiogram probes, which you can leave inside the patient for 72 hours. And you can look at the patient's LV filling and function, the biventricular function, and also the fluid responsiveness by looking at the collapsibility of the superior vena cava. So again, this is going to be helpful, and these probes are they're costly, but they're available in the market. Now you have to integrate all this together and see how you can manage your hemodynamic instability. So you see whether there is preload dependence. If the patient has preload dependence, you give him fluid. So volume infusion is done. Look at the echocardiogram. If the contractility is decreased, you give him dobutamine. You start dobutamine as an inotrope. How do you know your treatment is effective? So you should see whether your cardiac output has increased, and did the markers of tissue hypoxia decrease, like your base deficit, whether it has come down, whether the lactates have again come down. So these are indicators that your tissue hypoxia has decreased. So with every step that you do, you should always see whether your treatment is effective. So you should treat not only the macrocirculatory endpoints of your arterial blood pressure and cardiac output, but you should also look at the tissue-based indices. These are the microcirculatory endpoints. You should look at whether your mixed venous oxygen saturation has improved, whether your arterial lactate levels have come down, whether your capillary refill time has improved, which indicates your peripheral perfusion. Look at your urine output, whether the urine output is a very good marker of the visceral organ perfusion. So you should look whether the urine output has increased, and then look at whether your skin mottling has improved. So these are some of the tissue-based perfusion, tissue perfusion-based endpoints of resuscitation. So perioperative hemodynamic optimization should be done by optimizing the hemoglobin, the arterial oxygen content, as well as your cardiovascular performance. So we have already seen how we can improve the preload, the afterload, and the contractility by giving either vasopressors, fluid, or by giving inotropes. So along with it, you should also optimize the oxygen consumption by improving the microcirculation as well as the oxygen uptake. So we have now something known as personalized hemodynamic management, where the patients are, the individual hemodynamics of the patients are targeted, the personal targets are applied to these patients, and there is optimization of blood flow. Initially, we had something known as supranormalization of blood flow by Shoemaker and colleagues. Later on, there was the maximization, and right now we have moved to the personalized hemodynamic management, where there is optimization of blood flow. So the endpoints of goal-directed therapy in the OR and in the ICU are: you should have a mean arterial pressure in adults of more than 65, a CVP more than 8, urine output of more than 0.5 mils per kilogram per hour, a cardiac index of 2.5 to 4.2 liter per minute per meter squared, systemic vascular resistance index of above 1,500 and less than 2,500. Your mixed venous oxygen saturation should be more than 70%, and your stroke volume variation should be less than 10%. Now, if you look at the literature, there are a lot of studies which have shown the importance of hemodynamic optimization. Now, this is probably one trial which most of us are familiar with. This is the OPTIMIZE study, which optimized patients into two groups, where patients who underwent GI surgery were optimized into two groups to know whether application of the goal-directed therapy is helpful in preventing mortality and complications. But unfortunately, the study did not show that there was a benefit with early goal-directed therapy in patients undergoing gastrointestinal surgery. Another study which looked at the maintaining tissue perfusion in high-risk surgical patients by optimizing them. In the low-risk patients, there was no mortality benefit by giving goal-directed therapy, whereas in the high-risk patients, in patients who were at high risk, definitely patients who underwent goal-directed therapy, looking at the improving your fluid status, improving your contractility, and improving the afterload, it helped these patients, and it was shown that the mortality benefit was there. So this study concluded, this meta-analysis concluded that in high-risk surgical patients, the use of a hemodynamic protocol to maintain tissue perfusion decreased mortality and postoperative organ failure. But they emphasized that you should monitor cardiac output, calculating oxygen transport and consumption, which help to guide therapy. Another study in 2015 from Brazil, which again showed the importance of early goal-directed therapy in perioperative patients. Another one from anesthesia and analgesia, where they showed that the mortality rate improved as well as the complications were found to be less when patients had a preemptive strategy of hemodynamic monitoring and hemodynamic optimization. And there are many other studies in literature which have shown the importance of hemodynamic optimization. Now, this is a very interesting study from Susan Lobo and colleagues. Way back in 2013, almost 10 years back, they said that perioperative hemodynamic optimization or goal-directed therapy has shown to significantly decrease complications and the risk of death in high-risk patients who are undergoing non-cardiac surgery. So what they said was that when there are patients who are undergoing major surgeries, who are at risk of significant volume shifts during surgery, in these patients is always better if you could have a minimally invasive cardiac output monitor for testing the fluid responsiveness, and you optimize your preload and by looking at the urine output and signs of hypoperfusion by either giving fluids or by improving the contractility of the heart. And the second group of patients who are at high risk patients, what they said was you preemptively use the minimally invasive cardiac output and check the cardiac output and fluid responsiveness, and preemptively start them on dobutamine infusion to maximize the delivery of oxygen in these patients. And so this was the recommendation from Susan Lobo and colleagues. Now, looking at the different studies, these were some of the studies which was done in the non-cardiac surgery setup. Now, looking at the studies in the intensive care, we are all familiar with the reverse trial. Now, reverse trial was the person Emmanuel Reverse, who revolutionized the early goal-directed therapy, and they showed that the mortality benefit was very high if you optimize the patient's CVP, mean arterial pressure, and the central venous oxygen saturation by infusing red blood cells, inotropic agents, vasoactive agents, and fluids. So this was one trial which revolutionized the management of patients, especially in sepsis. However, the follow-up trials, that is the ARISE trial done in Australia and New Zealand, did not show any mortality benefit in patients who underwent either the conventional therapy or the early goal-directed therapy using fluid responsive management. Similarly, the process investigators in United States also, they did not show that there was mortality benefit when patients with early septic shock were either given a goal-directed therapy or the usual quality of care. Now, what does the guidelines say? The French guidelines for perioperative hemodynamic optimization says that in surgical patients who are considered high risk, it is recommended to titrate intraoperative fluid management by measuring stroke volume in order to reduce postoperative morbidity, hospital stay, and recovery of oral feeding for patients undergoing GI surgeries. What does the European Society of Anesthesiology say? They say that according to the European Society of Anesthesiology, goal-directed therapy decreases your postoperative complications and hospital length of stay when compared to standard fluid management. What does the American Society of Anesthesiologists say? They say that intraoperatively, you should have an integrated fluid management strategy by using either the dynamic indices of management. So you should have the goal-directed therapy. You should hit early and personalized. Hit early means you should do it preemptively. So which device for which patients? Now we have an umpteen number of devices, but presently all the monitors that are available right now give us the pulse pressure variation or the stroke volume variation on the screen if you have a intra-arterial pressure monitoring. So if for perioperative monitoring, if you don't expect any change in vascular resistance, you can use the minimally invasive cardiac output monitoring devices. If you expect major changes in the vascular resistance, you can go in for a PA catheter or the PICO monitoring devices. For ICU monitoring patients, especially patients who receive vasopressors, you should go in for a cardiac output monitoring device. Now, whether this is cost effective, we don't have any studies from India. However, there was a study from UK which showed that the goal-directed therapy for high-risk surgical patients was cost effective. However, there are certain limitations, like there is lack of high-level evidence, there is a lack of clear-cut approach. We don't know what are the exact targets, and there is an uncertain cost benefit because of the you need to spend money to get these cardiac output monitors for looking at the improvement in the fluid responsiveness. So we are having a few trials which are going to come out, like the Optimize 2 trial, the Gas Arc trial, as well as the iPegasus trial. So the results are awaited, which would give us a better idea in non-cardiac surgery. Presently, the perioperative goal-directed hemodynamic therapy has moved on from invasive monitoring to automated physiological closed-loop systems, where the hemodynamic monitor is connected to a closed-loop algorithm with a computer, and infusion pumps will give in fluid or the vasopressor as required. So it has evolved from way back in 1985 when Shoemaker said you need supraphysiological goals to present system where you give automated infusions of vasopressors and fluids. So summarizing, it is necessary to put hemodynamic variables and measures of your oxygen consumption and delivery into context in a way that once your macrohemodynamic parameters are normalized, we should have a check of the oxygen debt. You should solve the hemodynamic puzzle as quickly as possible. So you should improve your oxygen delivery as well as the oxygen consumption. So you should remember the 5 T's. Patients, the target population, that is, you should select the high-risk patients. The timing of intervention is you should start early. The type of intervention, you should combine fluids, vasopressors, or inotropes, depending on the condition. The target variables are the blood flow variables as well as the dynamic indices of fluid responsiveness, and you should personalize these according to the patient's hemodynamic status. So the physiological variables used to treat are based on correcting the systemic hemodynamic variables of pressure, flow, and oxygen delivery, with the assumption that there is hemodynamic coherence between your macro circulation and the micro circulation. So always check your tissue-based perfusion pressures, initiate your resuscitation, targeting the macro circulation, and always measure the micro circulation endpoints like the lactate, the base deficit, and the mixed venous oxygen saturation. So I would like to conclude by saying that treat the macrohemodynamic as soon as possible, but if the patient does not get better, look at the micro circulation and try to resuscitate it. Thank you very much for the opportunity.
Thank you, Dr. Vijesh. See, you are responsible for what you have said, but you are responsible for what you have understood also, because you have made it very clearly. You have discussed the subject from the down to earth level to the sky level. And just like a cost effective analysis, you balanced the sky level and the ground level. And now we are in the midway between the thing. And you said one size does not fit all. But your way of teaching the subject fits all. It fits well. It fits always and in all ways. So that is a credit to you. So Dr. Pradeep has brought a arrested heart to the level of hypotension, and you have brought the hypotension to the normal tension level. And now Dr. Parsardi is going to say how this pressure and volume changed during this cardiac physiology. Dr. Parsardi, please.
A very good day, everyone. And today's talk is about cardiac PV loop and cycle. And all my slides are available in www.painfreepartha.com website. And a few of the presentations are also available in YouTube channel Pain Free Partha. So before starting anything on academics, I put a big salute to the Professor Ravi Shankar, Director C Dreams, and our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry. Not only these images, there are few other images which are coming in the slides or taken from the internet for closed academic purpose only. Now, I put a cycle to know this is oriented towards cardiac cycle. So what is that? It is excitation of the myocardium. They develop a pressure gradient and a contraction, an opening of valves, ejection of blood. They started to relax. They develop again a pressure gradient, which is now down, opening of valves, flow of blood. Then go back again, excitation of myocardium, closure of valves, pressure gradient develops after contractions. Now, what is this PV loop? Pressure in y-axis and volume in x-axis. This is what is called a PV loop. And whenever we say PV loop, it is only about left ventricle. That is what we talk about when we say PV loop. There are four important phases. Ventricular filling, phase A, diastole. Isovolumetric contraction is phase B, which is systole. And ejection is phase C. It is also systole. And the ventricle starts to relax. It is phase T, diastole. Again, I will come back in different pictures. Now, this is C, isovolumetric contraction and ejection. These two are systole. This is a pressure volume loop. And the isovolumetric relaxation starts and the filling starts. This is diastole. Now, what is systole? What is B and C are systole, while A and D are diastole. Okay, A, B, C, D. D and A are diastole, while B and C are systole. The end diastolic pressure and end diastolic volume for the ventricle is there. That is what is EDV and EAP. As the ventricle begins to contract isovolumetrically, the volume does not change. The mitral valve closes and the left ventricular pressure increases. But the volume remains the same. That is what is called isovolumetric contractions, resulting in a vertical line because all valves are closed. Here you can see this is what is the isovolumetric contraction. Because filling has stopped, mitral valve is closed, the aortic valve is already closed, there are no valves open, so the volume remains the same. The left ventricle tries to contract with the same volume, the pressure increases, the volume does not change. This is isovolumetric contraction phase, phase B of systole. This is what happens. Both mitral valve and aortic valve are closed. The left ventricle starts to contract, tensed up, but there is no change in the volume. Now we go up. This is what is the isovolumetric contraction phase. As soon as the pressure goes up, the aortic valve opens and the ejection of blood starts. If the ejection of blood starts, the volume decreases. And this is rapid ejection and slow ejection. And this is what is C, that is also systole. So isovolumetric relaxation, contraction, rapid ejection and slow ejection, these form basically the systole. Now, once the LVP, again, so I'm telling you, aortic valve opens and ejection phase starts. The volume decreases and then decreases as the ventricle begins to relax. Now you see this is aortic ejection phase. Now the volume decreases. Mitral valve is closed. If the mitral valve is problem, there will be mitral regurgitation. So here the aortic valve opens and this is what is called the ejection phase. Once this is what I am telling again, the LV pain increases. This is what is the ejection phase. Now when the aortic valve closes at point 3, this is what is point 3. Aortic valve closes. The mitral valve is already closed. So the ventricle relaxes isovolumetrically. The volume does not change, but the pressure comes down from 125 to 5 or 6. Understand? This is what is called the isovolumetric relaxation phase. This is phase 3 to 4. This is what is called D. This starts diastole. Now we are told B and C are systole, D is diastole. Now when the left ventricular pressure starts falling and falls below mitral valve or the left atrial pressure, the mitral valve opens and filling starts from LA to LV. Mitral LA to LV, mitral valve opens, filling starts. So the volume increases because this is not a problematic left ventricle, it's a normal left ventricle. So the filling does not increase the pressure much. That is what is the compliance. Very well, good compliant left ventricle. The pressure does not increase. See, the pressure is very mildly increased with such an increase of volume from 50 to 130. Something like that. Here you can see 120, 130, and here it starts by 50. 70 ml increase, not much of increase. This is what is called the filling phase on rapid filling and slow filling. Rapid filling and slow filling, the last portion is the atrial systole. So these two forms, isovolumetric relaxation, rapid filling, slow filling, and atrial kick, these form the diastole. Now the stroke volume is end diastolic volume minus end systolic volume. So at the end of diastole, there is so much is there. Now the heart is pushing. There is such much is there. So 120 becomes 40. So 80 is out. That is the stroke volume. So what is ejection fraction? Stroke volume divided by total. So 80 divided by 120, that is what is 66%. That is what is we call as ejection fraction. I am very simple and many of the facts which you may be knowing already, but still I am repeating for the basis of people who are not very good in physiology. Now again I am telling end systolic volume is 50 ml, end diastolic volume is 120, mitral valve closes and the left ventricular isovolumetric contraction phase starts, aortic valve opens, rapid ejection phase and slow ejection phase, the aortic valve closes, the ventricle starts to relax and isovolumetric relaxation, the mitral valve opens, LV starts to fill, there is not much of increase in pressure, but the volume rises. So this is B and C is systole, contraction and ejection, relaxation and filling is diastole. Again, I am refreshing passive filling from the right atrium, and this part is called the atrial contraction, atrial systole. So when we have, there are certain clinical, I am just touching some clinical things. Now this is what we know, this the normal PV loop of the left ventricle. Now we have sometimes the LVH. That is what I told. The time it starts to fill up, the pressure is high. Even this pressure is high, the baseline. So if for 10 ml increase in volume, the pressure should not increase by 1 or 2. It is increasing by 5 or 6. That is what is called less compliant. Delta P by delta V. The increase in pressure is high for the increase in volume. That is what is called the compliance of the LV. As soon as the LV gets hypertrophied, the end diastolic pressure volume relationships. So this is the curve. Here you can see the curve, and this is slightly going up with this point. So this is a sign of diastolic dysfunction because of left ventricular hypertrophy. I will be coming back again for these slides. Now, if you do an exercise, see here, all these things increases. The volume increases, the stroke volume increases, the ejection increases, everything increases. The curve is, see here, the compliance does not change. The curve pattern does not change. Isovolumetric relaxation phase is straight line like this. Isovolumetric contraction phase is straight line like this. You can see the compliance is fine. You can see the ejection is fine. So in physiology, there may be increase in volume, there may be increase in cardiac output, but the curve structure does not change much. This is an increased inotropy and a decreased inotropy. Now we have got a preload problem. This is the normal curve. You can see the normal curve here. If there is a decreased preload, for example, diarrhea, for example, an ectopic pregnancy, excessive bleeding inside the pelvic cavity, there is no blood coming. So the volume filling up is low. And then you can see here that it cannot eject, no, it cannot eject more things and it is coming back again. But you see the curve structure is almost normal with a preload. When you see the increased preload, there is a lot of things. Yes, there is small increase in the pressure and the volume is increased and the pressure goes up, isovolumetric contraction, because the heart is normal. Preload is increased, preload is decreased. So that is what has happened. Here the preload is increased, here the preload is decreased. This curve, preload is decreased. This is ectopic. This we have given a lot of IV fluids. And see here, normal heart will function like this. But if you go to afterload, what is afterload? If you have an hypertension, if you have an aortic stenosis, the resistance to the left ventricular ejection is more. The LV is ejecting against more resistance. That is what I have told. It is hill up. If you are cycling in a mountain hill up, that is what is called the afterload. See, increase the afterload. The curve is like this. It is normal. Increased afterload. This is the normal curve. This is the decreased afterload. You can see the volume here coming down. This is at this pressure it starts to this. So this is increased afterload and this is decreased afterload. So there are so many terms. This is the stroke volume. This is the potential energy of the LV. This is the stroke work, end systolic pressure volume relationships, and diastolic pressure volume relationships, ejection fraction. There are so many terms. So why do we need this at all? PV loop, cardiac cycle, all these things. Now you take up mitral regurgitation. This is the normal loop. Now, as soon as this contracts, some portion goes into the aorta and some portion goes to the LA. Actually, the stroke volume may be high, but what is going into the aorta is maybe less. That is what I'm telling. Now, if the here into the aorta, if you decrease the resistance here more will be there, here more will be there, and LA will be less. So that is what happens when you give afterload reduction drugs in mitral regurgitation. If you give ramipril or enalapril, which decreases the afterload, here is the aorta. Aortic resistance is less. So this is pumping out and less resistance into the aorta, more blood will flow, and into the atrium, less blood will flow. So this is what happens. The contraction, because there is a leak of the mitral valve. So you cannot get a proper isovolumetric contraction phase or sometimes even an isovolumetric relaxation phase. There is leaking going on. The valve is not intact. So it is not as straight as this. The curve goes like this slightly and pushes like this. Now you can see the width is increased in regurgitations. The width is increased in regurgitation. This is what we should know. The width is increased in regurgitant lesions. Now you see a mitral stenosis. Everything is pulled down like this. This is the normal black one. And here you can see because less volume is coming to mitral valve is stenosed. How much blood it will get? It will not get 120. It will get only 80, 90. So it has to contract and push up this everything. So here the mitral stenosis, not much of changes except there is a decreased volume here, end diastolic. That is what is. Preload is decreased, end diastolic volume. This leads to a decrease in stroke volume. There is no blood, decrease in stroke volume. Because the end diastolic volume is decreases more than end diastolic volume, the stroke volume also decreases. So the width is little less. That is what is the stroke volume is less. And the curve is slightly pushed to the left. So this is what happens in mitral stenosis. If you know the curve, yes, you can play with cardiac physiology. Now again, I'm telling aortic stenosis. Here, reduced ventricular stroke volume due to increased afterload. Aorta is stenosed. The left ventricle cannot contract. Afterload is high. So what happens is the end systolic volume is very high. After the contraction and ejection, it cannot do. Here, the volume is there. It has ejected 100 ml or 90 ml. It has ejected only 40, 50 ml, and it is trying to do it at 70, 60 ml at very high pressures because there is aortic stenosis. So there is an increase. So there is a compensatory increase in diastolic volume. And here again, the isovolume. See, stenosed things. There is not much of change in the straight lines. See here, increased compensatory and this reduced ventricular stroke volume, increased afterload. The curve is like this high. The width is not raised. The width is less, height. That is what happens in aortic stenosis. But you see aortic regurgitation. The height is not done. See the regurgitant lesions, the width is broad. It's broad. There is no true phase of isovolumic relaxation. See here, because there is a leak here, aortic regurgitation. Whereas increase the LV volume. Here also there is a leak. It tries here. LV pushes aorta and aorta comes back again. So that is what is the problem. There is no proper isovolumetric relaxation. There is no proper isovolumetric contraction because the aorta is leaking and the compliance goes, the volume goes like this here. LV begins to contract, blood is still entering the LV. So there is no true LV. So the LV volume is very high here. So this is what is the aortic regurgitation. Now if you want to see here, this is the normal. The blue one is the normal. The green one is the mitral stenosis. What is aortic stenosis? See here, height is raised. In mitral regurgitation, see here, it is shifted to the right and the width is high. In aortic regurgitation, this is what is the curve. So unless you are sure of how the curve behaves in each valvular lesions, we are not very clear about the treatment schedule. Now you can see these are all, if you have familiar things like this, we don't go for unfamiliar things. So we are not bothered about what is RV PV loop, right ventricular PV loop. See here, the end as in systole is 125, while the RV is here 25. It tries to contract here and ejects out and comes in like this. This is what is an approximate RV PV loop. Now this is what is being called as normal RV PV loop. See, when there is a chronic increase of afterload, for example, severe pulmonary hypertension, a chronic increase, the RV cannot contract. Pulmonary hypertension is there. The afterload of the RV is increased. So it will look like an LV. The PV loop is look like an LV in an RV. So if it is going to be decompensation may be due to different reason. It may be a contractile dysfunction or it may be a regurgitant lesion, whatever it is, the decompensation, the RV pressure volume loop is pushed here to the right. In dilated cardiomyopathy, the ventricle becomes dilated without compensatory thickening of the valve. So that is very important. It becomes dilated. The valve is not thickened. The LV is unable to pump enough blood. The end systolic and end diastolic, both volumes increase. The end systolic volume is increased, end diastolic volume is increased, and the end systolic volume is increased. And the contractility is also decreased. So more blood is staying here. Now we know what is, we concentrate here. This is normal, but there is a diastolic dysfunction. The relaxation is not proper. It is not complete. So what happens is, here you can see the pressure is doing like this. It is not like this. Now you can see fire, diastolic heart failure. You can see this is what is the diastolic heart failure. The contraction is good, the ejection is good, the relaxation is also okay, but isovolumetric. But here the compliance is bad. The volume increases, the pressure increases very much. So this causes a diastolic failure because of some other cause. Diastolic, it may be a severe LVH, whatever it is, diastolic heart failure. But we go here, this is diastolic heart failure. The contractility is poor, systolic heart failure, it cannot contract. Now here, you can see here, the curve is similar. The compliance is not much, but it cannot push out. The volume is high, end systolic, the end diastolic volume is high. It contracts, but it cannot eject. It contracts, okay, but it is not powerfully ejecting here. And again, the end systolic volume and the end diastolic volume are high. The curve is shifted to the right. This is what is systolic failure, and this is what is diastolic failure. Any other thing about this PV loop? Yes, conductance, because the heart is filled with so much of blood. So the electrical conductance, blood without blood, may vary. This is what is being used in many of the cardiac output monitors and many other things. It is just a cardiac cycle. That is what we should know. It is systole and diastole. What happens is systole, isovolumetric contraction, ejection. Then comes back isovolumetric relaxation and rapid filling, slow filling, and atrial systole. It's a cardiac cycle, that's all. And thank you very much for the patient listening. Thank you very much. And subscribe to my YouTube channel, Pain Free Partha, for more videos. And thank you, doctor. And thank you all for the patient listening.
Thank you, Dr. Parthasarathi. So your thanks was quite interesting, not only by you, but the actress, even the outdated actress you have shown. It's okay. Now this is open for discussion. He has covered fully the basics of pressure volume loop, just like teaching an undergraduate student. He has taught all the postgraduates, and I think there is no chat box questions. So people can ask direct questions now. One question is there. How is perfusion index shown in blood? Help us in understanding the hemodynamics. This is to Dr. Vijesh. How the perfusion index shown in blood help us in understanding the hemodynamics?
Perfusion index is actually the ratio of the pulsatile blood to the non-pulsatile blood. So it is an indicator of the peripheral perfusion. So probably it is an indicator of it could be indicating, it could be showing you the, it could be closely related to the capillary refill time. So probably that is one way of looking at it. But other than that, I don't think there's any use of pulsatility index. The other use that is available is you can check whether your whether the block that you've given or the central neuraxial blockade is effective if there's an increase in the perfusion index. Well, to my knowledge, I think there's no other use for your pulsatile for the perfusion index. You can use the plethysmograph. The plethysmographic variability index can be used for fluid responsiveness. If you find that there is a more than 10, if it is more than 10, if your plethysmographic variability index is more than 10, then you can give fluid. That means the patient is fluid responsive. Regarding perfusion index, I'm not sure about whether you can use, except that it is correlated to your peripheral perfusion. Anything to add?
So I think you are clear. Hope Dr. Muthukumar is also convinced about your explanation. Now I am seeing Dr. Chittora sir is here. So Dr. Chittora sir can offer his comments. Sir, you are done.
Yes. What he has told about the perfusion index, I want to add one thing more. That perfusion index has become particularly in the general practice, has become a tool for the peripheral circulation, and so many times, as he had told, the neuraxial block. The effectivity of the neuraxial block can be judged by this, whether the effect will come or not. And thank you very much to the Parsarthi. He has given a very excellent talk. Thank you very much.
Thank you, sir. Sir, Dr. Agnihotri sir is in line. Dr. Agnihotri sir, you are in line. Sir has given a good feedback. He used to call me personally. Dr. V.M. Agnihotri sir.
Hello.
Please, sir.
Actually, this perfusion ratio, that is a capillary filling. We use one thing by knowing the diffusion ratio, plus simultaneously, if we use the pulse oximetry, you will see by the increasing in the circulation, the oxygen saturation curve is also going up. So these are two things are indication of the perfusion ratio. That much I can tell.
Thank you, sir. So many people have asked me the slides of mainly Dr. Pratik, because that prone CPR is quite interesting. And today night we will be sharing the YouTube link which has the lecture. Dr. Parsarthi, you want to add anything? Dr. Samir Saikia?
Hello.
Parsarthi, tell me. Dr. Pathas?
Congratulations to Pudukkottai team and Dr. Meenakshi Sundaram for this wonderful program, sir.
Oh, thanks, sir. Thank you very much. Today the participants have touched a peak of 80. So we are also very happy we are doing something useful for the anesthesia colleagues. Dr. Samir Saikia, you are in line. Yeah, I think if there are no more questions, YouTube link, I think there are no more questions. So today I will be sending the link, YouTube link. And if anyone wants to have that YouTube link, you please send me your mobile number with that introduction to 9361616969. It is my number only. So please text your phone number. So we will be sending you the YouTube link. Even the previous YouTube links also we are having. So if anyone wants to see a peculiar subject, we will be interested in sharing this YouTube link pertaining to that area. Now I request Dr. our secretary, Dr. Perisami, to offer vote of thanks. Dr. Perisami? As Dr. David is, Dr. Perisami, please. Your voice is not heard, Dr. Perisami. Dr. Perisami, your voice is not heard. Anyway, Dr. Perisami, on behalf of ISA Pudukkottai, I thank Dr. Manjunath who has accepted, but because he could not physically present now, I thank the faculty, Dr. Vijesh, Dr. Parsarthi, Dr. Prateep, and the distinguished delegates who have attended this webinar and honored us. And we thank A1 Logics and Accurella for their technical support. Thank you. Now we can end the webinar. Thank you then.
Thank you, sir.
This award actually belongs to someone else. So I was planning to not to say those words when I get an award like this, but